Okay, thank you very much for the opportunity to talk about our research today. And last year at the end of our talk, there were little white cards passed down to me and asked me what we found in the music therapy. So I gave a very brief comment, but this is now our more comprehensive analysis of the results. So what is music? Many people have asked the same questions over many years, and these are some of the quotes of certain famous philosophers. Music is a tonic to the saddened soul because it helps people to relieve their depression, their depressive symptoms. Music is a sound of universal laws promulgated. So it's a natural phenomenon and it expresses itself in many different ways. But I think Henry Longfellow is closer. Music is a universal language of mankind. And I'll explain why in a few minutes. But early evidence of music has been studied for a long time, and they're found in many different cultures. In 3000 BC, there are evidence that music is being played in Egypt, and also in ancient China, documents of how music is represented and played and recorded is already evident in 1200 BC. And what is the utility of music has been argued in many different ways. One of the psychologists, linguists, argued that music is the cheesecake of language development. And he argues that because we need sounds for communication, we learn how to communicate by listening to very specific sounds. But evidence shows that music actually happens way before language was developed and maybe actually is the beginning of language development. And there are many studies showing that even in Neanderthals, before full language is developed, they use music in some form of communication, such as hunting, gathering people together to chase an animal. They use drums to signify war, and then they also use music for courtship. And from what I learned in my music lessons, that music actually helps with memory, with the Gregorian chants when the monks and the priests have to recite long verses of biblical verses as well as to remember their prayers. Then if you put those words to music, it's actually easier to remember longer and easier to recall. And then music has been associated with that for many years. The Webster definition is that is the art of arranging tones and sounds in an orderly sequence so that it produces a unified and continuous composition. So that's the textbook definition. But is that just that? Some people do push that to the limit. A composition by John Cage is called 4 minutes 33 seconds. It's actually 4 minutes and 33 seconds of rest. So the performer came out and sit in front of a piano for 4 minutes and 33 seconds and then left, and everybody clapped. Some people argue that that is really playing that to the limits. Another very popular musical at the moment is actually called Stomp. It's still being played in New York, but they use everyday instruments, not really musical instruments, but everyday things like a falling book or throwing a basketball, bouncing a basketball, or just turning on and off a vacuum cleaner. It has all sorts of sounds to it, but if you do it to a rhythm, you can actually dance to these sounds. And music is actually a very highly personalized experience that elicits different emotions and memory based on the experience of an individual. So I will try and use this because it's available. So, So when we started our music therapy studies, We thought that classical music is what most people would want to listen to, at least for the generation that we're studying. But it has not been really the case. Mick Jagger and Paul McCartney are actually getting into the geriatric age range. So a lot of people like rock music, and what we learned is that music taste tends to solidify in your teenage years. So there's nothing wrong with that. People like different sorts of music, but we cannot assume that we all like one sort of music, and in fact, people have very different tastes. And when we actually run a music therapy study, one of the difficulty is to try to get to know the type of music that people like and will respond to. So why do we want to use music therapy? And because of time, I'm just not going to do it one by one. This is a slide I got from Dr. Alton Mueller. He is a professor of medicine in the University of in the Institute of Music and Medicine in Germany, in Heidelberg. And there's a whole institute to just study the relationship between music and medicine. But here are a number of very good reasons why we could try to use music for therapy. Because it's universal. Most people, even if you don't play it, can listen to music. So it may be very difficult for the musician to learn to play a piece, but anyone can just listen. Music can produce very strong emotions and can use us to train and coordinate motor actions. Some of the dancers would know it's hard to dance without music. You dance to the music. Music promotes social cohesion and gives us a peace, a sense of meaning, and also activate us. A lot of us, even if we don't like rap music, but if you just listen to the beats, you would just start rocking to the music. And it's a very powerful mechanism to get people to move. And music also links to specific memory, which we might reason why it might be helpful in Alzheimer's disease. But there are also other neurophysiological benefits. And I don't expect people to read this except for the fellows, which I'll have an exam on the music of cognition of music next week. But for those people who are neurologists or neurologically inclined, it takes many, many different parts of the brain to listen to and appreciate music. And there has been formal studies to look at that. The interesting thing is that it actually overlaps a lot with our language processing area. I won't go into the details of different type of music components that you listen to, but there's an overlap in the parietal region that is overlapping with the Wernicke's area in which we understand language. And then there's also a frontal region that overlaps with the Broca's area of our language. So that's closely linked to our language interpretation. But unlike language, it's not so lateralized. It also involves the right side of the brain much more than when we just listen to language. So it uses both the right side and the left side of the brain. And I don't have time to show a lot of the brain scan studies, but usually both the right side and the left side is stimulated at the same time when we listen to the music. So now moving more to the clinical care, what do you think is the most common precipitating factor that leads to long-term care placement? And click your button. So it's getting up to 130. So most people think that is disturbing behavior, which is indeed the second most common reason. The first most common is actually concurrent illness. So people with dementia if they happen to be sick with another reason, if they have a heart attack or have a stroke or have a fall and have a broken bone, then they are not safe to go home anymore. So concurrent illness is the most common, but the second most common cause is the disturbing behavior when they cannot cope at home, when their caregivers are having difficulty with deal with that. The other ones can contribute, but is not as much. And these behavioral and psychological symptoms of dementia come in many different flavors. The most common is agitation and anxiety. So people are just uncomfortable sitting at home anymore, and they become very anxious. If they're not with someone, they don't feel safe, then they have to be needing to have someone at home all the time. In a retired environment, sometimes the spouse might be available, but if one spouse is not there anymore, then that person may not be safe by themselves at home. Then you require caregivers, and that is a very strong reason that they need to be in a care facility. But there are many other types of behavioral symptoms, including disinhibition, depression, delusions, hallucinations, aggression, and uncommonly, but that happens, sexual disinhibition. So in order to study that, we suggested that maybe music is one of the things that we can calm people down. And then prior to our study, we have done some literature research. And most of the literature research on observational studies suggests that music has a calming effect. So we thought we'll target those symptoms and look for this effect in our music therapy study. So we enrolled people who have some sort of behavioral disorder based on a neuropsychiatric inventory, which is a tool that we ask people about the various symptoms that they experience in dementia and scale how serious it is. And people who scored 6 points or more are recruited, and they also have to have a concurrent diagnosis of Alzheimer's disease. Then we randomize them to music therapy because we know that we cannot really stop people from not listening to music. So we randomize by the timing of the therapy. So some people were randomized to get it immediately, and some people are randomized to get it a little bit later. But while they're waiting, we still assess them and follow them through and see what their changes are. And then there's a crossover. Once this group has finished one therapy, the other group will get the therapy later, and the other group will be waiting at that time. So we compared the waiting time to the treatment time right before and after and look at what has been changed. So this is the group that we have included in our study. 27 people have been included, slightly more female in the immediate group, but it's not significant. So overall, it's a balance between the waiting group and the immediate music therapy group, and they're not that different. And after treatment, we did find improvements. The color didn't come out right after I changed program, but this is supposed to highlight the neurobehavioral symptoms. So there are significant reduction in these behavioral symptoms after music therapy. While people were still waiting, maybe they were just anxious, but while they were waiting, their behavioral symptoms got worse. So this may be actually driving some of the differences between the group. But we do see a significant differences after the at the end of the two different groups. Overall function didn't really change very much. Unfortunately, they were still having some problems with everyday function, and also with their memory symptoms. It didn't significantly changed or improved. There's maybe a little trend that after music therapy is not as bad. And on quality of life, we also surprisingly didn't see it. We look at quality of life of the subjects and also look at quality of life of the caregivers. They still have to take care of the patient and they still have Alzheimer's at the end. But another thing that we measured physiologically is that cortisol, which is a measure of their stress hormone, it is significantly different after the music therapy compared to while they were waiting. So I think that we do have good clinical evidence that music can help with decreasing all these behavioral disturbances in patients. And we are the first one who have done it in a North American and an English-speaking environment, but other previous studies in Italy and in Japan has also shown similar findings. So we feel that is a feasible alternative compared to just giving people medications to try to calm people down. And for every studies that we have, we always have more questions at the end. So we treated music therapy as a black box. So you get this, and then there's the outcome. But what are the optimal methods of music therapy? I don't have the answer. I would leave that to the music therapist. In this particular program, they follow a specific schedule, but there are many different ways to deliver music. So what is a better way? That may be future studies. People ask about live music versus recorded music. The music therapists have very interactive methods interacting with the patients. Is it the same if you just play music or take them to a concert versus actually interacting with them to music and get them to dance, get them to sing? Maybe it's different. But we don't really know that. We don't have a proper study. What about patient engagement, getting the spouse or the caregiver to be engaged? Those are all good questions, and we don't have the answer. And we may have to do more studies to understand that. But in order to do this study, a lot of people are involved. Some here at the back helping up, and some have worked with us and have moved on to greener pastures. But I need to thank everyone participating in the study and everyone doing the study for us. Thank you.